Great. So we have a very distinguished panel, and we're going to go through the introductions in a minute, and also we've got very little time, so we're just going to go straight on with it. So the main goal here, really, for this panel is to address really the gap between the innovation lab and the clinic, as it were, by talking to the people inside the NHS whose job is it to implement such innovations, and founders as well, collaborating with the NHS and navigating the complexities of the system itself. On our panel here, we have Yinka Makinde, who's the former head, at the end here, former head of innovation at the NHSX, now the Director of Digital Workforce Strategy. The strategy is part of the UK government plan to increase emphasis on digital skills in healthcare, which includes aspects like digitisation patient records, granting virtual access to doctors and appointments, and educating clinicians and nurses to use these new tools as well. In the middle, we have Tara Donnelly, who you may remember from this session last year, actually, was until just February the Chief Digital Officer and Director of Digital Care Models and the Chief Digital Officer and Director of Digital Care Models at the NHS England, now founder of Digital Care, an organisation to support health tech innovators and healthcare organisations to revolutionise digital home care. And right next to me, we have Hiba Sher Khan, a women's health doctor who is also a clinical digital health advisor and mentor in this space as well. She's on the International Advisory Board for Headspace and works as a Deputy Chief Clinical Informations Officer at her NHS Trust and serves as a National Clinical Advisor for Digital Maternity for NHS England as well. She's been involved in local and national digital innovation projects for women's health and has an understanding of what is needed at the very front line and the potential for tech to transform the way we deliver care using smart AI and virtual care models. Please welcome them all, and I'm sure that's a very comprehensive panel. I will point out as well, just for some housekeeping, that Hiba and Yinka are here in their own capacity and expressing their own views, so nobody should get in trouble. Right. Let's start with some interesting things here. So we've been talking about lots of, I think what I'm trying to get to the bottom here is that we talk a lot about in the wired world about amazing applications and amazing services that can transform these things, but then we don't actually, sometimes the implementation of those can actually take some time to appear, or actually the reality doesn't change our lives as much. So I want to drill down into that. But I wanted to, from your inside the NHS, and now Tara outside of it as well, what is the best way to implement clinical innovation in the NHS that makes a real difference to patient outcomes?
So I'm particularly interested in the kind of end of the spectrum that is very highly evidenced. And obviously it takes a while for digital tools to get to that point. But that's where I believe we are on digital home care. And over the past 3 years, we have seen a seismic change in this country. The NHS was at a pretty low base about 3 years ago. There were a handful of places doing interesting work in digital home care. We've now just had the 100,000th person who has been cared for in a virtual ward. Around 4,000 people will have woken up this morning with hospital-level care, but in their own bed. And that's quite a sea change. That is a really good example of scale across every single part of the NHS. But of course, that is not something, when you're right at the beginning, you can possibly imagine. That's right at that evidenced end. And I think we need to really focus on those products that have taken the time to really develop their evidence base and make that very convincing and attractive, and ensure that there is good ROI and good value for money for the NHS. So I think if people are just starting out with those ideas, I mean, we were joking backstage about the number of people who do come to me and say, I'm thinking of building an app, and I kind of go, ooh, could you just stop first, right? There are 400,000 of them in English in health and care already. The barriers to entry are incredibly low now. We can, many of us can knock something up really quickly, but actually to get the evidence through, you're going to be spending at least £500,000. So maybe don't just knock up an app, maybe talk to some people and understand the problems that you're trying to deal with, and see if there's anything out there already that's maybe 60, 70%, and maybe partner. But I think be really, really thoughtful, because it will only be those ones at the top where the evidence is so compelling that the digital pathway is better than the face-to-face pathway that will succeed. But I would say reasons for optimism, because if I was doing this 4 years ago, I would say we've struggled to scale many digital tools. Actually, the position has changed when we've been very focused, put a mandate out there that it's a must-do for the NHS, and we've put some serious investment behind it. So that would be my... And the other thing is that if somebody is just starting out, I would recommend they go and have a conversation with their local Academic Health Science Network, or AHSN. They are here to support innovators in their patch, and they will give advice and signpost. And if you want to look them up, it's ahsnnetwork.com will tell you all about your local organisation set up to bridge the gap between industry and the NHS and make the most of it.
Yinka and Hiba, you mentioned partnering, Tara. So what is the best way? You know, if you've got something to come to you guys, what's the best way with partnering within the NHS? Introduce your product to hospitals, for example.
So I'll say so. On a local level, we run things like digital dens where different clinicians can come to us, patients can come to us, or different companies can come to us and say, okay, well, this is the problem we're solving or the problem that we need solving. I think you have to start, the recent formation of the ICSs meant that we are starting to bring together primary care, secondary care, and putting everyone in the right kind of room to say, well, what is the need, and understanding what the bigger problems are. Building apps, like Tara said, is not the solution all the time. If we're speaking about the NHS specifically, we've got huge problems of interoperability. We don't communicate with one another. I don't have access to a patient's record. I want to exist in a system where I'm not solving a niche problem with an app, but where a patient tells a story once and only once, where I have complete visibility from a clinician's perspective of saying, well, not telling that story once means I deliver better care. It means I order less tests. It means there's less resources used. It means that we're all kind of getting to that goal much quicker, and we're optimizing those pathways in terms of finances and also time. So we have to first, I would advise companies that those are the problems that you need to be looking to solve. And then when you do have those, actually coming in and creating a case study with your local ICS and being able to produce that data and say, well, these are the outcomes that we have, is how you then start to scale. There are lots of things that we've taken up in my trust, in my capacity as a digital leader for innovation there, which we know have been used and have been used well elsewhere. So actually it's in our best interest sector-wide to start implementing that and rolling that out for all of our patients across North West London, because it works in everyone's interest. And that data being there already is what helps us scale it.
Yeah, sorry.
Yeah, so from a sort of I'm just going to mention NHS England because I know what they have. So they do have the opportunity to bring your solutions and work with a particular unit within NHS England, which is a digital partnering sort of hub, really. And by interfacing with people in those teams, you can make sure that you get your solutions to a level in terms of standards. You can get advice on what's expected if you are trying to work with colleagues in the sector. And then if we look at the new structure, which is still very new, came into act in July last year, I believe, the ICSs, so these are the integrated care systems. There's a really great platform to start, as Hiba said, to work in partnership with local healthcare communities to see how you can try and solve their problems. You've really got to look at the problems that they're facing, and also you've got to try and help them to win the battle that they're also facing internally. So you might find a really enthusiastic champion who is very keen to work with you, but they still have their own barriers to overcome. So they need to still try and get business cases signed off by the finance director, who often doesn't get this stuff still. So really think about how you're positioning your technologies in terms of whether it's generating clinical pathway efficiencies, whether it's workforce efficiencies, or whether it's process efficiencies, or in fact, whether it's helping to reduce risk, and sort of try and demonstrate those cases, because that will help the person that you're working with to try and get this over the line internally.
With the you mentioned interoperability there as well. It's like, so when you're talking at this level, are we talking about, is it even possible, just as from a layman's point of view, is it even possible to approach the NHS and say, we have a solution for this particular problem, and this could work across the country? Or do you have to start with just individual areas and jurisdictions rather than go out there? Like, is it because we supposedly have an IT system that can speak to everybody within the NHS, but if you speak to your local doctor, they've got lots of things to say about that. But how do you actually, do you have to start in a localised area? One of the startups this morning was talking about they were working with NHS Cornwall, for example. Or can you go big straight away?
You can't
go not at all
straight away. No, but that's a deliberate move so that there will be very few national products across the NHS, and some of them will be a really useful front end for future products like the NHS app.
Yeah.
So that's now integrated with several hundred different types of apps. So it's a nice front door to them, but there is no desire to have lots and lots of national platforms, because the feeling is that will really reduce the amount of kind of competition in the market and mean products don't develop as well. Primary care is really interesting. There are only really 2 products out there. It's a bit of a duopoly. Right. There isn't a national solution. Local practices and their areas decide which product to use, and it may be that individual users are not that fond of them. It's very similar in secondary care. 2 big providers take up a lot of the market. Actually, in the digital innovation space, there's a lively market of lots of choices. And we think that's a good thing, that the market should fill its boots with innovative products that the NHS can make use of, rather than be one kind of, with a nice blue tick on it, national solution, because the evidence is that's not great in the longer term.
Excellent. Spoken like a true founder of a new company.
Thank you.
Obviously, with some of these things, we're talking about how, a lot of the things we would actually expect, some of the changes in the NHS would actually be brought about already, but it's not. But I don't want to be too negative. Hiba, can you give us some examples really of situations where these things in the NHS have brought about change? Yeah. Something we can champion rather than just say, where are they? Why isn't this changing fast enough?
Mm-hmm. So things have changed from a patient perspective and a clinician perspective. So we're starting to see, across the country, there's still an element of levelling up that needs to happen. But with electronic health records and those that are integrating between primary care and secondary care, the implementation of summary care records, we're starting to get to a point where actually we do have visibility. The Greater Manchester Healthcare Record is a great example of why 3 million people will have their records completely visible across primary care and secondary care settings, which is a great win for that area. What we are seeing from a patient perspective, what we have achieved so far is that we are starting to give patients access to their data, to being able to see their results, their imaging results, their pathology results. We're doing that with companies like PKB. We're giving them patients the opportunity to start to take control of booking their own appointments, to have visibility of that. So these are wins, being able to say that actually I can put a patient on a PIFU path, like a patient-initiated follow-up pathway when I discharge them from clinic, is a great win, because I'm saving efficiency, I'm saving an appointment slot for somebody who really needs it. So there are companies who are helping support those pathways, and these are things that we have achieved in terms of accessibility, in terms of clinical efficiencies, being able to, these EPR systems are allowing us to, they're giving us back time with the patient. I don't want to spend my 15-minute slot with a patient just documenting with my back to them. I want to be able to move on, and having that information visible, being able to access that patient's London care record and see what medication they're on already gives me a great basis to move on to the next step. And these are things that weren't there 5-10 years ago, and I've seen them in the last decade emerge. The problem is that we do have discrepancies within the system, and there are disparities in different services and different units across the country are doing these things very differently. A patient and clinician experience is still fragmented and unfortunately still very different.
How does this, speaking to that, how does this digital maturity map? What does it look like? I mean, where are the differences in a geographical map of the UK? So who has got it good, as it were? You mentioned Manchester. Where is it being implemented, and where is it sorely lacking?
There are pockets of great digital maturity, and actually it's not necessarily a north-south divide either. So at the moment, we're driving a levelling up agenda to get everyone up to the same level in terms of EPR coverage, and obviously then what follows is interoperability. And we have to do that. And in fact, there's a national target to get that sorted by March 2025. And it's a top priority. Once we've got everyone to the same level, then we can start doing the fun stuff. Then we can start to look at how do we bolt in some of these other more innovative solutions into the core infrastructure. But until we get everyone up to the same level, it's very difficult to start introducing great technologies that allow you to sort of receive care in one area and have a similar experience in another part of the country. People move around a lot these days. So I think at the moment, the priority is levelling up, and it's EPR. It's less sexy, but it's really fundamental. Interoperability is really key as well, because rather than having a one-size-fits-all solution, which we've tried and tested many years ago and it didn't work out, we're giving regions and localities the freedom and opportunity to choose what systems they want, but so long as they all are complying with the same standards, so it allows other innovative solutions to bolt into the core infrastructure. But maturity does vary across the country.
What are the barriers then? Like you're saying, that's how they'll get to this level playing field. But so if they've got the agency in order to do that within certain parameters, what are the barriers to stopping that happening?
I suppose one could say there are barriers around how money is used in different areas, and these are all my personal views. So I would say potentially how money is used. Different areas get similar amounts of money, but how they choose to prioritise the spend of that money varies. Access to the skills, my area of interest, access to having the right skills to implement these things, and also the digital maturity of the population, of the people who we need to actually use the applications and embrace the opportunity that digital can provide. So, and also leadership plays a huge role as well. So, there's also a great recognition that we need to invest in our people. It's really not just about the technology. In fact, it's probably 20% about the technology and 80% about everything else. And so there's now a realization that we need to invest in people, and that starts with the leadership and sort of creating the right cultures and mindset to really lead this properly.
Tara, just your view there as well, so having been in the public sector in this regard, and then very recently you can see it from both sides, going from the private sector as well.
No, I definitely can. And just for the audience's benefit, so I've spent 30 years in the NHS, most of that time spent running hospitals, and then the last 7 or so years more in the digital space, and I've just set up on my own. And I was just listening to the response about digital maturity, because actually it's a bit different for digital home care. It is more consistent. And we've mentioned ICSs a couple of times. These are the 42 health and care districts that the NHS in England is now chopped up into. And every single ICS has a tech-enabled virtual ward. Most of them have got more than one service. They might have tech support to their care homes, or they're doing long-term condition management. And I think we're at the foothills of something incredibly exciting here about the level of hospital level care that we're able to provide to people at home. And it doesn't map with digital maturity. It's interesting. People have been able to leapfrog. And in fact, the first two biggest virtual wards were both in what are described as digital deserts, because they actually were able to use this technology to substitute for paper and pen, and they were able to do that. And ultimately, we want these systems to completely interoperate with their EPR, but it is interesting that when needs must, people were able to make that progress at a fast pace. So I think it is a slightly different story, in that we're able to say that across every single ICS in England, People with acute respiratory infection and frailty have a model of remote monitoring, and some of that will be completely remote if that's fine for the patient, and probably particularly in the pneumonias and so on. For somebody living with frailty, it'll often be combined with quite a lot of care in the home. So it's not a kind of one size fits all, it's really quite personalised. So I think, yes, it's a different story than simply kind of looking at provision of EPR, which is a fundamental platform, but you can do some digitally innovative things even in areas that haven't got that level of maturity for whatever reason.
You mentioned acute and chronic care there, and I'm wondering if there's a difference between the two and whether one lends itself more to digital home care, or is like this digitisation care that has a potential to help treatment both chronic conditions and acute ones. But I'm wondering how we differ between those two. And obviously they have different subsets of people that generally class into those sorts of...
Yes, and the same technology can be used for both. But I think perhaps the reason that the acute has been really prioritised, the definition of virtual ward care is somebody who would otherwise have been in a hospital bed, links to our low levels of bed capacity in this country. So we are low on beds by almost every measure that you can have compared to the kind of European average, and we're low on staff. And this is a way to create capacity in quite a different way that's very efficient in terms of staff. You still need more staff to staff more beds, but you probably need a third more if it's a virtual model than if it was a physical care model, because the technology is helping dashboard patients and prioritise them so that clinicians can focus on the ones they need to most. So I can see why that would be where to begin, but I actually think there's probably as much to go after in the long-term condition management. If we think that 70% of hospital beds have somebody in because they're having an exacerbation of their long-term condition, and we're seeing some amazing results across the country. So in Airedale, for example, they have reduced the admission rate of people with COPD, the emergency admission rate, by 50% in the cohort who are supported by really quite a simple digital tool at home. If we could see results like this across the country, I think we could start to see a very different winter than we have historically. If you think about the level of seasonality of conditions like COPD, heart failure is another one where we're getting super interesting results actually in West London. So I think I'd like to see both fully incorporated, and in fact I wouldn't like to stop there. I'd like to support everybody living in a care home as well with some digital vital sign technology that can just provide huge reassurance to the staff that they don't need to go to hospital. We have a lot of evidence that there are a lot of unnecessary conveyances, admissions and attendances for people living in care homes who probably will find this most punishing. We know a lot now about the harms of hospitalisation, and they're very real, particularly if somebody has any form of cognitive issue at all. It can deteriorate, and in many cases permanently. So I just feel we need to move heaven and earth to keep those people as safely as they can be in the place that they call home. And it's great news that digital tools have now arrived that are cheap and effective and can do that.
Speaking of those digital tools, though, Hiba, we've got these digital skills, and we're talking about them in the NHS. But what about on the patient side? We're talking about the elderly generations, and they're more likely to be using NHS services. Are they ready, in your experience, are they ready for digital innovation? What work needs to be done to enable, say, a 90-year-old patient to use virtual care services, for example, from their home?
Well, it might be that patient cohort necessarily isn't ready yet, but we have to recognise that some of the ones that are, and actually be able to shift that balance and say, how do we give the majority kind of younger population a digital front door as their primary source of accessing healthcare so that we free up some resources?
Before you go on, who have you identified as being ready then?
Well, I would say that people, it comes down to your IT literacy, right? The people who are engaging in kind of IT services for other parts of their life, their day-to-day runs off the back of an app or some kind of platform, the ones who are kind of time poor, that cohort is already ready to be able to say, well, actually access your primary care physician primarily through an online platform. I can't remember the last time I actually spoke to my GP, but I use a service called Patchwork really quickly, and it gets me everything I need very, very fast. And actually what we're doing then is then freeing up that time for those older 90-year-old patients who, in a primary care setting, who also will benefit from technology such as the home care and the different kind of vital signs that we can monitor at home. Now, like we said, the NHS has always been able to move heaven and earth for acute things. If someone is dying, we're able to do whatever it takes to save a life, but we've always neglected and not been able to get there with chronic care. There are lots of opportunities here for AI to be able to help triage our patients appropriately, to be able to plug them into the system, especially the elderly generation, of saying, well, these are the vital signs we picked up, which then need to come in and generate a physical clinician appointment.
I think it's also a user design challenge point.
Yeah.
Right, about designing technology that can be accessible to people who might traditionally have not been able to do it. So I think about a really interesting evaluation of the Croydon virtual ward, where they had a quarter of their patients were over 80, and they were asked about how ease of use and satisfaction with the technology, and they rated it 94%. Now it's an armband, and it provides 4G in the home, so it assumes nothing. And that has been very cleverly put together by the innovators involved. They've thought this through so it will work equally for any age or any level of digital confidence. So I think we need to be pushing at those sorts of boundaries to make sure that everybody who would like to, this is an offer, not a mandate, you can always stay in hospital if you want to do that, but that it's possible for many more parts of community than we might have previously expected to be part of it.
We're running low on time. Yinka, I wanted to let you all actually sort of end with really, I want to know some examples that you've come across, maybe from other jurisdictions, other countries, that you think we should either you take inspiration from or emulating here in the UK. In our call, I think you mentioned the French healthcare system. Is that correct?
I did. I mean, I'm not an expert on what they've done, but I know that they have achieved sort of rolling out the electronic healthcare record across their entire population. Now, I'm not up to date with where they've taken that next, but it gives them a brilliant opportunity now to, I guess, move their population to the next phase of digital transformation, really, and sort of starting to use some of these other more interesting technologies. But I think we've already seen some positive developments in this country as well. So all of the stuff that was achieved very quickly at lightning speed during the whole pandemic, let's not take that away from us. We achieved a lot, and now what we're trying to do is to build on those successes.
Yeah.
In, albeit slightly slower rate than it was, but I think we are still seeing the appetite to build on what we started during those years.
The last question, I think, is for Hiba. So we've talked a lot about what these, the efficiencies that these sort of initiatives can drive. But I want to get your view on what the extent about this efficiency is about cost saving, and what is it about? To what extent is it about actually improving whether the service is being delivered? Two different things, really.
Yeah, I think we have to move towards more of a value-based healthcare delivery system where we're saying, well, actually, how many people are we keeping out of hospital? How much are we predicting earlier on? And therefore, being able to map that out with the different patient outcomes. We don't do enough of that in the NHS. And actually, that requires a lot of clinical leadership. It needs a lot of the right kind of people to come together and say, well, how do we design for a service and not just a particular condition? And we're starting to see, again, there are pockets of innovation that are going on. We've seen examples of complete virtual fracture clinic pathways where patients don't actually ever have to come into contact with a physical clinician at all. These are the kinds of models that we need to start to implement so that we say, well, actually, that's where I see the future of us, where we're going.
And lastly, Tara, after 30 years, or roughly in the NHS, and then just a couple of months in the private sector.
3 weeks.
Yeah, 3 weeks in the private sector. What's been the most surprising thing on the other side of the fence for you?
Surprising.
Yeah, exactly.
Oh, I don't know what. So I feel as though I've made the move because I really am passionate about moving on digital home care. So I feel in some ways I'm doing the same job, but kind of on my own terms and with clients I'm choosing. So it feels like more of the same, but perhaps a little greater freedom.
Okay. Thank you very much, our panelists. Thank you. Please.